Okay, great. I think I'm the last speaker. It's hard to follow such amazing speakers. So I'm going to be talking about robotics. Let's see here. Can you guys see my screen?
Yes, yes,
Yes,
we
very
see.
well.
Perfect. So here are my disclosures. And so for those people that are in the United States, I will be talking about some off-label applications. So in terms of our objectives today, we'll talk about the motivation about why we'd be interested in robotics. And we'll talk about some advanced applications for robotics and spine. We'll talk about percutaneous TLIF as it relates to Camden's triangle. We'll talk about advanced spinal pelvic fixation, and we'll introduce the concept of the transfacet TLIF. So if we look at a robot, if you look by definition, it should be a machine that resembles a human being. And so that's not what we have right now. What we have right now is more of a cobot, something that is a computer-aided robotic device designed to assist the person. So you know, in some of these movies, it's the robot is fully autonomous and doing all the work by itself, but that's not what we have. Right now, what we have is basically a very expensive drill guide. So here is a picture, video of how it works. It gets you in the trajectory, but you still, as a surgeon, have to put in the screw by yourself. Um, and so that's what we currently have. And so whenever you have a new technology, you have this what we call a hype cycle. So there's a lot of excitement that happens, and then you start having some negative press. I think that some people in the United States may have seen that there was recently a warning to one of the robotic companies about their technology. And so you start having some negative press, and then you start having some problems, and then maybe you reach some type of equilibrium where we figure out, okay, this is the best application for this technology. If we look at the chasm of implementing a new technology, there's usually this gray zone whether we're going to cross that chasm. And this, whether you cross this chasm, I think depends on how low this disappointment is. So if this disappointment is very, very low, then you may not cross that chasm. Um, and so traditionally, sometimes we have this thing where we start thinking about us versus them. So man versus machine. So some of the younger people may not know who Gary Kasparov is. I asked one of the residents, they had no idea, but I'm old enough to remember this. Gary was playing against this Deep Blue IBM computer, and you can see the stress on his face because he felt that he had the world, the pressure of the world on him. This was in 1997. If you fast forward for 20 years, you see that he preaches a different scripture now. Now he says, you know, machines have calculations, we have understanding. And so we actually should not look at the machines and robotics and so on as a adversary, but rather something to help us achieve our goals. So if we look at, you know, what's going to be the ideal navigation or imaging system, we've had brilliant talks by my colleagues. We really want to have real-time imaging. We want to avoid fixating on the patient. If we can avoid a preoperative CT, that would be great. We should be able to recalibrate easy. I love the work that Dr. Mirza was doing with the ultrasound. We want to decrease radiation, and we should not increase OR time. Right now, the current iteration of robotics don't do any of the top four. But that doesn't mean that it's not going to happen. It's just that that's the iteration that we have right now. So can we use the robot for applications other than placement of pedicle screws? So one of the great things about a robot is that it is able to target deep structures, and it could do that while decreasing the damage to overlying tissues, and we don't have to do a lot of dissection. So we use this actually to target Camden's triangle. I had a previous webinar this morning on Camden's triangle. And so we can see that Camden's triangle can be a very deep space and it can be very, very small. And to target it could be very tricky. But we've used the robot actually for this application. So here's a patient, 64-year-old gentleman who had previous problems with general anesthesia, did not want to have general anesthesia, and he had a spondylolisthesis at L5S1. So we're able to target the pedicles using the robot, but then also target Camden's triangle. So then we're able to place an interbody fusion using this. We do this ESP block as well as a spinal anesthesia. We have the patient awake, and then we put in the screws traditionally, and then we're actually able to target Camden's triangle. And so you can see in this case here, there's no blood loss. Is a percutaneous case, and these patients in general do very well. We published a case series about this using the robot to do that, and we can see that we had 10 cases, 4 of them were done awake. Our EBL, because it's percutaneous, is less than 100 cc's, and you can see now most of our length of stays is in 0s and 1s. How about percutaneous iliac fixation? This for tumors and unstable sacral pelvic fractures. So here's a gentleman who had a invasive colorectal carcinoma. He had this very metastatic and large cancer here. And then if you look very carefully at a CT scan, he had this sacral insufficiency fracture here. And so, how do you treat this patient? He has very bad kind of prognosis, but he has a lot of pain. So what we do now is we can plan the screws in the lumbar spine. And then this is where I think the real power of the robotics is that you can actually plan the tulip heads all line up together underneath the skin. And so then you can do these cases percutaneous. So these are the Wiltse incisions that we did for the lumbar screws. And then this incision here is for the iliac screw that went in this way. And so it always is very challenging when I'm doing it with fellows. They're like, oh no, Dr. Abd-El-Barr, there's something wrong. And I tell them, no, there's nothing wrong. What happens is underneath the skin, the tulip heads line up. And this is very difficult to do as a human being. And so you can do this case now. This was our first case we ever did, was 150 cc blood loss, but now we're going to get down to 20 and 30 cc blood loss. And our construct looks like everybody else's, but it's completely percutaneous. We can get this patient home post-op day 1. He only ended up living for 3 to 4 months after his diagnosis, but at least we gave him some quality of life. How about unstable sacral fractures? These can be in terms of high velocity traumas or old people with insufficiency fractures and fragility fractures. So here's a 65-year-old lady. She had a head-on motor vehicle accident. A lot of these patients, have deep vein thrombosis. So you don't want to do a big decompression because then you're going to have to put them on blood thinners and so on. So if we can do this all percutaneously, that would be great. You can see here just how comminuted her sacral fracture is. So this is done in coordination with our trauma colleagues. So here they had an acetabular fracture. They do all this, and then we are kind of sometimes dodging their metal. So we can do this again, completely percutaneous, 25 cc blood loss, right? And now we can put her on blood thinners faster. She's 2 years out and extremely happy with her abilities to walk and so on. I don't think we could have done this any other way. And sometimes it's challenging. They have external fixation devices. They have 2 to 3 transiliac, transsacral screws, but we can still kind of dodge metal there. So this is our original case series, and we've had some really good results. We had one complication that we had. How about the transfacet TLIF? So, we've been very obsessed with Camden's triangle, but as we've learned more, we've found that some people's Camden's triangle is just too small to put a safe interbody fusion there. And that's really gotten us to think about this transfacet pathway, which is keeping the facet joint in the middle of our trajectory into the disc. We've published this paper looking at these different pathways. Here's a case I think I showed at the previous webinar, 35-year-old. We do this transfacet pathway. Now we've actually set the table, and we haven't done this yet in a human, but I hope in the next few months, where we've actually shown that you can dock the robot on the facet joint and hopefully use the robot then to do the interbody fusion and do this completely percutaneous. So in terms of future directions, I think intelligent decompression, I think will definitely be there. One of the things right now, the robotic heart technology is a little bit slow. So I call it sometimes affectionately the slow bot. And I think I'm faster. I call myself the Mobot. But at some day, the slow bot will get faster. And then more versatile end effectors are coming down the pipeline. So just to conclude, I think robotic surgery is an emerging and exciting field of spine surgery. I think beyond placement of pedicle screws, I think there are a lot of other applications that the robot can be very helpful for. And with that, I'll conclude. Thank you.
Thank you very much for your really interesting and a very nice presentation. There is some question about this topic.
I think
I have a question, if I can. Yes, is on the same way of the one of Salman. We know that the technology, especially at the beginning, are very have a very high cost. In your opinion, what must be the break-even points of surgery to justify this technology? And I mean, all the centers that have spine surgery may use this technology, or in your experience, there is some specific indication or a number of procedures that give a cost effectiveness of this technology, as right now is very, very expensive.
Yeah, that's a great question. I think that as it stands now, the robots are extremely expensive. They are very slow. And so I think using them for certain indications makes sense. I think that the indications that I like to use the robot for are with these spinal pelvic fixation, where I can do everything percutaneously. I don't think that even the regular navigation will allow you to really plan out and make it very precise where you put those tulip heads, and so that you can do these cases completely percutaneous, especially if there's previous instrumentation, these transiliac screws that get in your way and so on. So you can really, it has the advantage of amazing navigation, but then also the implementation is perfect, right? And so as we know, just because you can plan it very well doesn't mean as humans we implement it very well. So I use the robot for distinct cases, not all the time. I think for a 1-level or 2-level fusion, the Mobot is still faster than the slow bot.
Excellent talk. I like it, especially the sarcopelvic fixation by the robot. But is there, as you have mentioned, the way that we will use the robot is in the similar to the abdominal surgeons in tumor resections, even in intradural tumor resections. Do you think there will be a time to come for this?
Yeah, great question. So I was doing a very difficult case a couple of days ago, where we have to do very precise dissection. And I told the resident, do you think the robot can do this? And currently, no, right? And we can't lose our surgical skills. But I do think that in the future, that may be coming down the line. But right now, the technology is just not there. I think we still need to learn how to dissect soft tissue and so on. But maybe in the future it will happen. Dr. Theresa,
Theresa, I have a question for you.
Thanks so much. That was a great talk. Always fun to learn from you and fun to reflect on being part of that hype period of the robot training with you and under you down at Duke. My question was around your case on the spinal pelvic fixation. Two questions. One, with the Wiltse incision, have you considered doing like a midline incision to the fascia? Just because those for the S2AI screws, the incisions are so medial compared to your pedicle screw incisions. And then the second question was about fusion. So, I'm getting tempted to use the robot to do this for like MIS, T10 to pelvis, etc. Obviously, this was a very different case. It was more of a palliative surgery for someone for stabilization. But are you comfortable at this point feeling like you get a good fusion to do it for more of a degen case?
Yeah, great question. So the first question about the Wiltse, that was our very first case, and right now we're actually not doing Wiltses. We're mostly doing them as just percutaneous, just stab incisions. So usually, there isn't a need to do midline, and so I've kind of gone away from that. So not a lot of times will I do Wiltse incisions, and I think that was just our first kind of through the learning curve. In terms of fusion, I think that's a really good question. I think that I don't know the answer to that. We've had, knock on wood, some really good experience with them in the traumatic field. But in terms of, for long segment fusions, are we going to be able to fuse across that segment or not? I don't know the answer to that at this point. Okay, well, it's been a real pleasure having everybody on this webinar. I think I've learned more than, I actually taught today, and it's so great to see people from all over the world. And thank you, Dr. Mehmet, for setting this up. I think this is a great first start to the collaboration between all the different WFNS committees.
Really, it was great. I enjoyed all the speakers. Thanks a lot. See you again.
Bye.
Bye. Thank you very much.
Bye.